Hello. Hi there. I'm Dr. Omar Bey, and welcome to OBHealthy, the Doctor's Lounge. We are a group of Black physicians, and we're here for two major reasons. The first reason is to improve the health of people of African descent. The second reason is to encourage young Black males to consider medicine because it's so important that we have people that look like us taking care of us. So that's so important to us as Black physicians and Black male physicians that we encourage our young to go into medicine. The webinar is every second Saturday at 1 o'clock. And you can see our past webinars. All you have to do is go to OB Healthy and hit the doctor's lounge area. And there'll be a little camera there. You can hit that. That'll bring up all of our past webinars. Or you can go to the YouTube sign on the website and hit that, and it'll bring it up as well. Okay, I would like to thank OB Healthy for allowing us to bring this to you because without their support, we really could not do this. All right. Remember, when you go into YouTube, please subscribe so we can continue to bring that YouTube aspect to you. Okay. And the most important thing that I can say today is please do not change any aspect of your medical care until you consult your physician because truly only your doctor can take care of you from a medical, best take care of you from a medical standpoint. All righty. We're our topic today is infectious disease. And I am so happy to have Dr. Dial Hewlett with us today. He is an infectious disease specialist. And there's so many, I should say, so many diseases out there that come under his realm that we should be talking about. You know, COVID was an infection, it was a viral infection, and we all had to live through that. So the topics today are relevant, they're happening, they're what's out there, what we have to take care of. So I'm so excited to deliver this webinar to you today. What I'd like to do is I'd like to have Dr. Sprock, we're going to introduce and understand you as those that follow us, you understand that the doctors, they will sign on as oh, here they're coming in now. They will sign on as time goes in. Some of the doctors are still making rounds, some of them are still in surgery, but as time goes on, they will sign on.
Even not firing missiles, the big missile batteries are not firing.
Dr. Court, you have a background going on.
Oh, wait.
Yeah, I hear the ball game going on. Could you center your camera a little bit there, Dr. Court? We're missing your chin. Let's get you squared away. There you are. There you are. All righty. We're going to start off with Dr. Sprott. Please, could you introduce yourself?
Yeah, I'm Kendall Sprott. I'm a board certified pediatrician that's retired. I grew up in Beaumont, Texas. I went to Morehouse College and then got my medical degree from New Jersey Medical School, which is now part of Rutgers. And I'm happy to be with you.
Oh, thank you. Thank you. Dr. Court, it's your turn.
I'm originally from Guyana, but I went to school, HBCS school, Harvard University. Graduated in 1980. My specialty is internal medicine. I practice in East Orange, New Jersey.
All righty. Thank you. And I'm Dr. Omar Bey. I, of course, went to UMDMJ, which is now Rutgers. And boy, oh boy, just happy to be here with all of, oh yes, I'm a pulmonary critical care physician that is retired from that aspect. And now I'm Director of Nutritional Support at the ICU at Bacterial Medical Center. So we are so happy to have Dr. Dial Hewlett here with us. And Dr. Hewlett, what I'd like for you to do is just give us an idea of who you are, how you got where you are, and because I believe it or not, I met Dr. Hewlett at the National Medical Association. He gave a lecture, and I think your lecture was on, I'm not sure exactly what infection it was, but that it was such a great lecture. I went up to him and I said, "You have to come on my webinar. You just have to come here." And he graciously come and to be a part of this. So, Dr. Hewlett, just tell us who you are and thank you for being a part of our webinar.
Sure. Thank you, Dr. Bey, and it's an honor to be here. and I'm happy to talk about infectious diseases. As Dr. Bay said, my name is Dial Hewlett Jr., and I grew up in Cleveland, Ohio, and I'm a product of the public schools in Cleveland. My role models were my parents. My father was an educator and also worked 2 other jobs at the Cleveland Post Office, and also worked on the weekends mixing paint at Sears. And that was what he had to do in those days in order to sort of get us through. My mother was an advocate and was always an advocate for our education for myself and my 2 younger siblings. I actually went to school at the University of Wisconsin on an athletic scholarship, and it was by accident that I got into medical school. I say that because I had no intention of going to medical school, but a counselor who was there, who happened to be a brother, he came up to me and he said, well, now that your track career is coming to an end, what are you going to be doing for the rest of your life? And I said, well, I'm not really certain. I had done some summer jobs and I didn't really know. I was kind of floundering. He said, well, we're trying to interest young Black men and women as well to go to medical school. And I told him, I said, that's ridiculous. I said, I haven't taken the necessary courses. I came up here to run track, and I got into school here because I could run faster than everybody else and not because I was smarter. And he said, well, you can work on these courses. And if you are able to get through these courses, maybe you can get into the medical school. And I said, well, it's kind of a long shot and it's going to cost me money. Well, to make a long story short, they made loans available to me. I took advantage of it. And one of the things that he mentioned to me was that he said, your highest aptitude when you came here was in biological science. No one ever told me that. I scored in the 98th percentile in biological sciences on the aptitude tests. And he said, you are ideally suited for medicine. And as soon as I started taking those courses, I started to really enjoy them, and I developed an enjoyment for learning. And that was actually how I got into medical school. I finished medical school at the University of Wisconsin, and I then went on to Harlem Hospital Center in New York, which was part of Columbia University College of Physicians and Surgeons under the direction of Dr. Gerald Thompson. And I actually had a great mentor in medical school, the Dr. George Lithcott, who was a pediatrician, and he was instrumental in the eradication of smallpox. And he sort of took me under his wing and he said, I want you to go to Harlem Hospital because Jerry Thompson's program, he says, you'll grow there. He predicted when I was a medical student that I would become a chief resident. And I didn't know anything about chief medical residencies, but lo and behold, Dr. Thompson wanted me to be a chief resident. So I became a chief resident. I left Harlem Hospital and I went on to Montefiore Medical Center in the Bronx and Albert Einstein, and I did my infectious disease fellowship. And here I am now after I spent a number of years as chief of infectious diseases at Lincoln Hospital in the Bronx. We were serving mostly our underserved patients in the South Bronx. Some of the sickest people in New York City were there at that hospital. And I was there at the time that the HIV pandemic first started. And I think that was one of the reasons why I was able to sort of build a career around not only treating sick patients, but also learning about this new disease and teaming up with people at New York Medical College to record some of our observations on these patients, largely patients with HIV and tuberculosis. And following my time at Lincoln Hospital, I then went into the pharmaceutical industry. Again, that was by accident because I had no intention of going into the pharmaceutical industry. But what happened was they ended my affiliation with the New York Medical College. And subsequently, I went into the pharmaceutical industry, and I was with Pfizer working in clinical drug development and medical affairs for about 23 years before retiring from the pharmaceutical industry. And now I'm currently the medical director for tuberculosis services at the Westchester County Department of Medicine. And one of the things that I really enjoy now is serving as chair of the task force for vaccines and therapeutics for the for the National Medical Association, NMA, as Dr. Bay mentioned. So thank you for having me today, and I'm just happy to be here.
Oh, excellent. Well, you perked my ears when you said tuberculosis, being a pulmonologist, we're going to have to talk about that a little bit.
Sure.
What I like to, excuse me, what I'd like to do is Dr. Ali just joined us. Let me get him to introduce himself, and then we'll move forward with Dr. Hewlett. Go ahead, Dr. Ali.
Hi, good morning from the West Coast. So my name is Dr. Mazhar Ali. I'm a gastroenterologist at Scripps Clinic in San Diego.
Oh, excellent, excellent. That's our West Coast team member. So
West Coast representing.
yes, yes, please. So what I'd like to do is, Dr. Hewlett, just for the audience out there, just tell us what infectious disease is, maybe what a bacteria is, what a virus is, what a fungal organism is, just to give us some basic background as to what we're going to talk about today.
Sure. All of these organisms are they're living organisms, and bacteria and fungal organisms and also viruses can invade our body and cause infections. Many times when these organisms invade our bodies, nothing really happens. Sometimes, more often than not, when a virus, for example, enters our body, like the cold virus, we get a mild congestion, and that's kind of the end of it. Maybe we feel a little bit under the weather for a couple of days, and that's the end of it. But sometimes viruses like the flu can actually cause serious problems, especially in people who are debilitated, people who are older, and in our very young children. And it can lead to pneumonia and hospitalization, and in some cases, death. We use the term communicable disease, or sometimes people often we use the term infectious diseases, but communicable diseases are diseases which can be passed on from person to person. And of course, we remember very vividly what happened 5 years ago with the COVID pandemic. A lot of people don't realize that the causative organism in that was a virus. It was a coronavirus. And that coronavirus had actually been identified probably back in the 1930s. They identified this virus as a cause of respiratory illness in animals. And then in the late 1960s, they actually identified the virus as a cause of the common cold in children who were someplace in the Midwest, I think in Minnesota or one of the Midwestern states. Subsequently, we didn't think too much about coronaviruses until all of a sudden there was this terrible, terrible outbreak that killed a lot of people in Asia and also in Canada. And there were a few deaths here in the United States, and they called it SARS. It was SARS-CoV-1. And that was when this coronavirus, all of a sudden, it went from being something that was causing just a mild kind of an infection to something that was causing something terrible. And the people that got that first wave of infection back in the year 2000, I think it was in 2001, 2002, 2003, somewhere in that period of time, it had a very high mortality rate associated with it. And then later on, we started to see the coronavirus coming back into our scope. And in 2020, we ended up with this pandemic from a virus that previously was felt to be relatively harmless. All of a sudden, it was causing deaths of all of these people. And we know here in the United States, it caused the deaths of over 1 million people. The important thing to know about these communicable diseases is that some of the communicable diseases, some of them which are viruses, some of which are bacteria, can be prevented. And one of the keys here is that they came up with a vaccination that would prevent the coronavirus infection from causing severe illness, hospitalization, and death. And I think all of you are familiar with the COVID vaccines that came out. And I personally am a proponent of vaccines, although I know there's a lot of politics surrounding a lot of this right now. But I don't think that there's anyone who can deny the benefit of those COVID vaccines. And as we look at other viruses, the smallpox was a virus that was killing many, many people. Thousands and thousands of people were dying in Europe and even here in the United States. But when a vaccine was developed and we could prevent that communicable disease, smallpox disappeared. In the early 1960s, you had a lot of children who were dying from measles, a lot of children who were being hospitalized and debilitated because of measles. And then in 1963, we had the development and the approval of the first measles vaccine. And then all of a sudden, we saw measles sort of almost disappearing. And unfortunately, because we have a number of people who live here in the United States who don't believe in the effectiveness and in the safety of the vaccines, they refuse to have their children vaccinated. And now, as all of us know, there have been over 1,000 cases of measles that have occurred, largely in the Western states in Texas, but it's involved Canada. There are over 1,000 cases in Canada. There are cases in certain districts of Mexico. And this happens because the measles is so contagious. It's a communicable disease, and it's probably one of the most contagious diseases that is known to man. In our field of infectious diseases and in public health, we use an index that we call the RO index. And what we use it for is to determine the infectiousness of a virus or some other kind of an infection. And the RO for the measles is between 12 and 18. And what that means is that for every single person who gets the measles, they will go on to infect 12 to 18 other people. And so in order to prevent the spread of the measles, we have to make sure that about 95% of the people are vaccinated in order to achieve what we call herd immunity. And so that's where we are right now. I think I'm certainly on the soapbox about vaccines when it comes to the measles, when it comes to when it came to things like smallpox. I think we have to be just as vigilant about whooping cough, and we have to be just as vigilant about the polio vaccines, because here in the metropolitan New York area, just 2-3 years ago, we had a case of polio right up in the county next to the county where I am working in public health. We had a young man who developed paralytic polio. And a lot of people don't realize that's a virus that causes paralysis. And it's irreversible once it begins. And that can be prevented. A lot of people don't remember, and we probably don't remember it because we didn't live through it. But back in the 1930s and 1940s, you had thousands of people who were paralyzed because of polio. You had people in what they call iron lungs, and you had to have special schools for children with polio that were built on one floor so that they could be wheeled in wheelchairs and so that they could learn from their wheelchairs. And now, fortunately, we don't have to have that. But if we fail to take advantage of the vaccinations that we have to prevent communicable diseases, we're going to be back to where we were back in the 1920s and 1930s. Wow. I know that's long-winded, but once you get me started on this, I can't stop.
That was great. That was great. Let me, Dr. Aluya, you has just joined us. Dr. Aluya, please, can you introduce yourself?
Yes, hi. Good afternoon, everybody. It's a pleasure to be here once again among such esteemed, brilliant brothers who've been doing this for so long. People often forget that it takes time and effort to put this together. I must first of all say thank you, Dr. Omar Bey, for doing this and for having Dr. Hewitt come on. It's a pleasure. Somebody just talked about you and said, "Oh, I know him, you know." Yes, my name is Nelson Aluya. I'm a medicine and pediatrics trained. Um, Presently, I call myself a medical advocate. I stand on the premise of working and defending the values of healthcare when it comes to people of color, especially those of African descent. I've been a professor of medicine at Rutgers University, former chief medical officer, and a medical consultant for St. James Health. And I also run a private practice as well in New Jersey, in the town called Irvington. So it's a pleasure to be here and share my ideas and the thoughts I have when it comes to medicine and care that we provide. Thank you.
Excellent, excellent. The thing of it is that, thank you, Dr. Aluya. Dr. Hewlett, tell me about mutations. Now, COVID, and the one thing about COVID is that every time we turned around, we were getting a new vaccine and a new vaccine. What's the deal with it? I know these organisms want to live just like everything else wants to live, and they're trying to figure out how they can stay alive, and we're trying to figure out how to kill them.
Yes.
But describe a mutation. What is a mutation when I have a treatment for a particular disease, I give that treatment, and all of a sudden that organism is no longer effective. That treatment is no longer effective.
Mhm. Well, the organisms, whether they're bacteria or fungal organisms or viruses, but especially viruses, they can mutate. They have they're made up of genes, and there can be mutations within the genetic makeup of that organism. And the organisms are actually quite smart because they know where they're being attacked. And by mutating and by changing, essentially a mutation is essentially just a change in their genetic composition, they can resist the points of action where some of the antiviral medications might be attacking. And this will then render that particular treatment as not being effective. The same is true with vaccinations. If the genetic makeup of the virus changes, the vaccines are directed against a particular set of genes, a particular sequence of genes. And so if that is changed, then the vaccines become less effective. And this is how the viruses adapt. We know that this occurs very regularly with influenza. So each year with the influenza virus, we see what we call a genetic drift. And that's like a slight change from one year to the next in the genetic makeup of that influenza virus. But every roughly, maybe it might be 5 years, it might be 8 years, could be as long as 10, you see what we call a genetic shift. And when there is a genetic shift, that's a dramatic change in the genetic makeup. And when that happens, that is essentially setting the stage for what we call a pandemic, a worldwide infection, because what happens then is that you have a new genetic makeup to which most people have never been exposed. And we may not actually have all of the components in the vaccine in order to protect people adequately. And so these mutations essentially can fool us and can outsmart the vaccines. And I think that people who are familiar with HIV are very well aware of the importance of mutations, because we know that if people are infected with HIV, they may be initially infected with a strain of HIV that is susceptible to the first-line medications. And then for whatever reason, they decide they're not going to take the medications after being on the medications for a few weeks. The medications will actually set the stage for and trigger the development of the mutations, because that virus that's still left behind is going to say, I can actually outsmart this medicine, and I can then protect myself. So if you start to take that same medicine again, it's no longer going to work. And so that's the importance of mutations. And in the hospitals, we're very concerned about mutations because with the bacteria that cause infections in our hospitalized patients, one of the things that we get called about very often as infectious disease specialists is to see patients who have had operations, routine operations like a hip replacement or an appendix or something like that. And then all of a sudden we have infection in a wound. And these infections can be caused by bacteria that are resistant to all of the first line antibiotics. And this can be very detrimental to the patient who goes into the hospital for what should be a routine procedure. And then all of a sudden, we can't treat them as well as we would like to because of the mutations that have occurred. And this is what we call antimicrobial resistance. So these are mutations. And this is something that goes on. And this is why we had to have so many changes with the COVID vaccines. And I think moving forward, we have the same thing happening with influenza vaccine. And moving forward, I think we're hopefully going to have combination vaccines that are going to all be in the same vial. So we can give influenza and COVID vaccines at the same time. That's what I think we're hoping.
Interesting. Interesting. Dr. Court, your hands. Oh, Dr. Court, your hands open. Go ahead.
For me? Okay.
Yes, sir.
Doctor, every year there's a different flu vaccine being given. How was it determined what would be the strain that would strike each year? Is there a particular formula, or is it cyclic, or what?
Yes, I'm glad you asked that because there is unfortunately, we pulled out of the World Health Organization. And the World Health Organization monitors the strains of influenza that are prevalent or predominating around the world. And they look at that, and then they use the data from all the different areas of the world to try to figure out and try to predict what changes are likely to occur, and to then provide the manufacturers with that information so that will guide them on how to manufacture what to include in the manufacture of the new influenza vaccines. There is a committee in the United States. The FDA basically runs this committee, and it meets 6 times a year, called VRBPAC committee. And that committee has about 15 members, and they look at all of this data that is coming in from World Health, and they then are charged with advising the manufacturers here in the United States on what should be in the influenza virus. Now, some years they're right on the money. Other years, they might be a little bit off. But I think that it's been a great system so far. And I think the people that are doing the work are, they're very credible scientists, and they're trying to look at everything objectively. And I think importantly, because this was a committee that was put together by the FDA, they're trying to be not under the influence of have commercial biases in the way that they do their work.
Yes.
Thank you so much.
Excellent. Dr. Sprock, please.
Yeah, one of the things, and thank you, Dr. Hewlett. I'm sort of a contemporary in that I was dealing with HIV in children when Newark had I guess the unluckiest aspect of having a high heroin addiction, and a lot of the transmission of HIV was via IV drug use, and then through sexual transmission to the mates, and then in women that had HIV, they had babies, and the babies would acquire the virus, and then they would die in droves. Unfortunately, I lived through that, and Dr. Oleski, who was one of my colleagues, helped determine that HIV occurred in children, and then they helped to develop vaccines that prevented maternal transmission of HIV from mothers to kids, and then it went away. And so with things like influenza and respiratory syncytial virus and and other types of, rhinovirus. These are viruses that usually are mostly seasonal. And so we tend to look at the winter or the cold months is when, and even with COVID, when the people are inside, they're not outside. And since it's a respiratory transmission of the virus, a lot of the infections occur seasonally when the weather is cold. And this kind of tracks around the world. Same kind of thing happens. And one of the things that, with the WHO, they would track what kind of viruses are causing influenza and when RSV and all these other things come. And we're predicting what might be the trend by the time it went through Asia and then Africa and then Australia and then through the South Pacific and then back into the States. And so they would collect this data and then try and figure out. And typically, most of the influenza vaccines contain 3 different strains of influenza, basically those 3 that they think are most likely to occur. Sometimes one of the strains that was in last year's vaccine remains because they still think that it might come, even though it might not have been so bad. And so that's what tends to happen with influenza. And for most healthcare workers, it's a requirement that you take these influenza vaccines, number 1, to protect you from getting it, but also number 2, to prevent you from spreading it. When he talked about the issue of if you have an infection, who you then might infect. Well, if you have the vaccine and you can't get the infection, then you can't pass it on. And that's one of the things that happen, in terms of people that are anti-vaccine, because when I was a resident, we had a number of both bacteria and viral infections that caused lots of disease. And I'd say that, over half of the admissions that I saw as a pediatric resident were infectious disease related. We had infectious diarrhea, mostly viral. They developed a vaccine for that. Now we don't see those admissions. And a lot of meningitis. I recall having, 19 spinal taps a night because of some of the bacterial meningitis from H. influenza type B and from pneumococcus and from meningococcus. We did have vaccines for all of those things and they went away. The H. influenza caused not only pneumonia, but otitis media. And so we eliminated all of these things. And the measles, the mumps, and the rubella, which caused death. All of those viral infections were extremely prevalent. When I was growing up, I got almost all of them. I had chicken pox, I had measles. I didn't have rubella. I found out when I was an attending that I didn't have rubella, so I had to take a rubella vaccine. But I think that when I went through residency, I saw lots of deaths related to infectious disease and lots of damage. They say morbidity, which kills, or mortality, which kills, but morbidity, which damages. And it was very, very hard for me to have to tell parents about kids that were going to die imminently because they went into septic shock where the bacteria got into the bloodstream and damaged the liver and the kidney and the heart and the lungs from preventable diseases that we have vaccines for. Right. But as time went on and we developed more vaccines, a lot of these things didn't happen. So people don't see those deaths and see the morbidity that occurs. And now you see, in Texas, there was a child that died from measles. And I don't know how a parent can live with themselves if they have a child that dies from an infectious disease that was preventable from the vaccine. And so because we don't see these types of things anymore, people discount. And sometimes you have people that are supposed to be intelligent and speak, and then they discount it until at some point they say they start to change when they see a death, because I don't think that you can justify a death of children or even adults from diseases that are preventable. And so, I've always been a big proponent of vaccines. And a lot of the things that you spoke about in terms of, bacterial infections, people need to understand that most of these organisms that cause infections are living and are out there.
Yeah.
Viral infections, the virus can't reproduce itself outside of a living cell. And so in order for those viruses to replicate or reproduce themselves, they have to be inside a living cell even they're animal or human, and then they can reproduce themselves. And sometimes they damage the cell that they're in and cause problems related to that damaged cell, and sometimes they don't. Sometimes they stay there and they kind of hide out and don't cause damage. And again, many people don't realize, but the entire surface of our body is covered by bacteria. Those bacteria are there. They usually don't cause any harm, but if you break the skin, a cut or a puncture, those bacteria that are on the surface of your skin can get under the skin, start to divide, start to cause an infection, reproduce themselves, and then the body tends to attack it with the white cells. And again, that's an important component. And we talk about antibiotics, but it's much more important for your immune system, the white cells that attack the bacteria and the viruses to be healthy and intact. And that's what happened with HIV when the virus attacked a particular type of white cell, and then antibiotics didn't help them because the infections were the immune system wasn't strong enough to sort of defeat these organisms and cause the death. So it is important for people to understand that the process of an infection is related to the organism and how it gets into your system. You know, a lot of the viruses can get into your system through the respiratory tract. Some of them get into your system via your GI tract. And some will only cause you harm if they're bloodborne. And so the issues of how you protect yourself against the various viruses will depend upon how the virus can get into your system and cause you problems. And again, with viral infections, there usually is a point where you're exposed to it. Nothing happens except that the virus gets into the cells, they start to reproduce. And after a certain point of time, you then start to develop symptoms. And then once you develop symptoms, your body then reacts to them, a period of time goes away. And hopefully, after another series of days, your infectious disease is eliminated by your immune system, and that's the end of it. Unfortunately, for some folks, that's not the course. Sometimes the immune system isn't strong enough, or there are other barriers, mechanical barriers that might exist where you can't defeat it, and it will persist and sometimes linger. So it is important for you to kind of understand what that time cycle is in terms of exposure, because you know with COVID we talked about an exposure, and if at a certain point, or you test to see if you still have it, and you still have it, and you still have it, and then finally you don't have it. Then once you don't have it, you can't spread it. But people need to understand those sequence of events with most of these types of infections. So not only can they protect themselves, but they can prevent the spread of disease to others.
Excellent, excellent, excellent. Now, what I want to talk to the audience about is please ask your questions. Don't be afraid to type in your question. I know that you're listening to the doctors talk, but we want to be here to answer your medical questions. So please don't hesitate to ask your questions. Dr. Aluya, you have your hand up, please.
Yes, thank you so much. And since we're still on the issue of vaccines, I'm sure infectious disease is so huge and big, and there's so much we can talk about. We have viruses, we have bacteria, we have fungus, and we have worms or helminths and all that. I'm sure our great doctor will talk about each and every one of them. But you know, since we're still on vaccines and virus infections and all that, look, viruses have always been with us, and they'll always be. I'm sure they were created before even God created, you know, humanity or man in the hierarchy of where things are. So there's a reason why they're here, and you know, they complement some of the things we do, and has over time helped us evolve to who we are and what we have become. You know, a few things. The fact is this: as humanity evolved and got to where we became the most dominant species on Earth, where we control our environment, physical and emotional and everything else, including you know biomedical. A lot of things come out. They're good fallouts and they're bad fallouts for everything. One of the things that we've been able to achieve is controlling how we get infected. And thank God to Edward Jenner and all the work that they did way back then, in 1797 or when they came out with
Yeah.
the vaccine. But again, if you take back that has been traced to an African origin. The fact of vaccine and vaccination truly came from Africa. So for those who don't know, that's a strong fact. But the question, the issue, and I have a question for you, Doc. Do vaccines work? Yes, they do. Truly, they really do. They've saved human beings. In America, just like Dr. Sprott was just alluding to, we don't see these things anymore because we vaccinate children here. Now, the number one cause of death in ages less than 5 across the globe is infectious, straight up. And one of the ways we've been able to handle that is vaccinate our children against pneumonia. And the different vaccine protocol that they have, the 9, the 17, the 27, and all that, the 22. These are strains that come together that help at any point in time help protect us. So vaccines do work. But then the other things that come out of it, I'm sure we're going to talk about that subsequently. But when Dr. Herwitz was talking about antigenic shift and then antigenic drift, that's huge and important. And I hear you talk about vaccine, COVID again, and how it evolved and all that. So there are natural selections, how God or humanity or nature has created that as we evolve, viruses evolve as well. And those are natural selective processes that allow virus to stay and do the things that we do. Now, the question for you, Dr. Herwitz, what have we as humanity done to help protect us, but at the same time have caused us harm? And especially in the word I'm going to use, gain of function experiments and researches. What's your thought about all that?
Well, it's a tough question, Doctor. I think that what we have done, I would say, I don't know that aside from clean water, that there's anything that vaccines actually are a close second in terms of maintaining the health and the prevention of disease that the scientific community has done. That's how I see it as an infectious disease person. There's a saying, and you're probably familiar with this: an ounce of prevention is worth a pound of cure. And although we in infectious diseases often are called in to try to treat when we have a sick patient in the hospital, it's far better for us to be able to have given a vaccine to someone so that they would not actually have to be in the hospital in the first place, for us to have to give them high-powered IV antibiotics. But I think that vaccines certainly have gone a long way in this whole area. As far as the way that things are going in the future, I guess we'll have to sort of look at that. But I don't know. I think that of the contributions, vaccines are right there at the top. You mentioned Jenner and the smallpox vaccine, and then there are others who developed other vaccines subsequently. And one other thing that you mentioned, and I agree when you talk about the African continent in terms of the contributions, a lot of people may not realize the stimulus for the development of the pneumococcal vaccine actually had its origins in Africa. And it was really because of economics. The people who owned and operated the gold mines back in the late 1800s, when they had African workers coming in to work in those gold mines, they noticed that a large percentage of those African workers were getting sick and they were dying. And they discovered subsequently in the late 1800s and early 1900s that it was pneumococcal pneumonia that they were dying from, because they were getting a pneumoconiosis, they were getting a chemical irritation in their lungs, and that was predisposing them to getting this bacterial infection in their lungs, pneumonia, and it was killing people at a very high rate. And so that wasn't good for the gold mining business. And so they actually called upon scientists to try to develop vaccines. A British scientist was called upon, and then subsequently work was done here in the United States to develop a pneumococcal vaccine. So that's just a little tidbit for you. But I know that I've kind of dodged around your original question.
Great, great. Dr. Court, your hand is up. I know, Dr. Hewlett, you got plenty of questions coming. Dr. Court, go ahead.
Dr. Hewlett, what is sepsis? And we frequently have to tell family members patient is septic. Can you break it down for the audience?
Sure. I'm glad you asked that question, Dr. Court. Sepsis is essentially it's a systemic inflammatory reaction where usually it's a bacteria, and that bacteria has actually gained entry into the patient's bloodstream, and it is causing a inflammatory reaction that is affecting just about all of the organs in the body. So in causing that, it's causing injury most often to the blood vessels. So you're getting inflammation of the blood vessels. In the lungs, it can cause adult respiratory distress syndrome because the permeability of the lungs is changing and the patient goes into respiratory failure. In the brain, you have sometimes it can cause disorientation and confusion. In the bloodstream, it can cause problems with coagulation. In the kidneys, of course, we all know about acute kidney injury. So all of these are the systemic manifestations, if you will, of infection. And some people believe, and it's been proven, that it's not necessarily the bacteria per se, but you have components of the bacteria. We talk about the gram-negative bacteria. There's a lipid layer that they think is related to causing sepsis from gram-negatives. And then there's also a membrane of the bacteria that they call teichoic acid that triggers off this systemic inflammatory reaction. But it's a systemic reaction, so it's actually the body's reaction to this infection. And if we can catch people early enough, we can maintain them and we can treat them with antibiotics. But I always tell everyone when they call upon us to talk to a patient to talk about sepsis and to treat sepsis, we can't just treat the sepsis. Sepsis is, I view it as a three-legged stool. One leg in treatment is the antibiotic. Everybody knows that. But then you can't ignore the other two legs of the stool, which is hemodynamic stability. We have to make sure that we do everything that we can to stabilize the patient hemodynamically in terms of their cardiovascular and respiratory function, giving them the kind of support that sometimes has to be given in the ICU. And the third big thing, which is one of the things that we're called in to really investigate, is what's the source of this sepsis. More often than not, if we look at adults with sepsis, probably over 80% of the time, 85% of the time, maybe it's coming from the urinary tract, or it may be coming from the respiratory tract. I mean, those are the two big areas that are the sources of sepsis in most people. And then there are other places where it can come from as well. And so we want to make sure that we identify the source, because if we can identify the source, if it's like an abscess or something like that, we must drain that abscess in order to be successful. So that's pretty much what sepsis is. And one of the things to keep in mind about sepsis is that not in all of the cases of sepsis are we going to be able to identify a bacteria that is causing it or a causative organism. We, of course, always encourage the drawing of blood cultures before we give antibiotics. And oftentimes within a day, we'll grow bacteria that will tell us exactly what's causing it. But in the majority of the cases, we don't actually have a causative organism. So we're treating empirically, but it's certainly helpful if we have a bacterium that is isolated, like an E. coli from somebody with the urinary tract infection, or a pneumococcus from someone with sepsis from pneumonia. So I hope that answered your question.
Yes, a follow-up question. What should be done on an emergency basis, say within an hour or two?
Well, I think the protocols all call for the patient being placed on appropriate antibiotics within that first hour. An assessment of the patient's hemodynamic stability. I think is the other important thing. So we want to know what that patient's oxygen saturation is, because if that patient isn't at an adequate level of oxygen saturation, then we need to call in people who are going to be able to provide respiratory support for the patient. The patient may need to be intubated. That's part of the initial assessment. And then, of course, we want to make sure that the patient is not hemodynamically unstable in terms of if they are hypotensive. We have to make sure that they're getting proper fluid resuscitation. And then the other thing, which is part of this management, which our colleagues like Dr. Bay are very familiar with, is we have to make sure that if we are resuscitating them with fluids, that we're not overdoing it. And in order for us to make sure of that, we have to monitor, and they may have to have a Swan-Ganz catheter or other type of device put in to make sure that they are not being overhydrated. And we then have to make assessments, and this is what our intensivists know about the administration of pressor agents. So all of these are part of the initial assessment, I think, that has to take place. And a lot of that, I think, goes on now in the emergency room during that first initial encounter. I don't know if our other colleagues who are probably closer to the emergency room side might want to comment on that further.
Yeah, I think that as far as initially, when you're talking about sepsis, there are several things. Number one, you talked about hemodynamic. The hemodynamic means that keeping the blood pressure up appropriately. There are medications that you give to keep the blood pressure up. As far as the oxygen is concerned, as you stated, intubating the patient, putting them on the machine that will mechanically breathe for them, making sure that their kidneys are working, that they're able to urinate appropriately. And also, as you stated, given these fluids that and all of that, we have to make sure that we don't overhydrate, because if you overhydrate, then that extra fluid goes into the lung tissues and makes the breathing even worse. So it's a fine line that you choose here, or try to select here, that's going to make this patient better. And antibiotics, early antibiotics, even though you may not have the organism identified, you may have the site of, you may have suggested, I said, or a site that you think that may be the culprit. And that will give you an idea of what type of organism it may be. So that appropriate antibiotic is, well, to put it this way, a broad spectrum or antibiotic that covers a lot of bacteria may be started initially until you get your cultures back, and then that specific antibiotic for that particular bacteria will be given. And there are a couple questions that I have for you too, but Dr. Sprock has his hands up, and after Dr. Sprock, there are a couple questions that have come in from the audience. Dr. Sprock, go ahead.
Yeah, I think there are a couple of things that I wanted to touch on. One is the issue of, the sepsis. And again, for most of the cases, we're talking about a bacterial type of infection that causes that cascade function. And then the question that Dr. Hewlett mentioned is that bacteria gets into the blood, and very often you'll have a positive blood culture. And you have to ask yourself the question, not only of where did it come from, but where might it go? And so in certain types of infections, it may be a localized bacterial infection, but something happens along the way and the bacteria gets into the blood. And once the bacteria gets into the blood, it may only be there for a short period of time, and we call that a transient bacteremia. And with the transient bacteremia, your immune system might be able to control it. But sometimes it's beyond the ability of your immune system, and it goes beyond its ability to handle it. And that's when you can get this cascade effect where you start to have damage to various organs. When in the days of when we didn't have the vaccines to prevent meningitis, very often the bacteria that caused the meningitis was present in the nose and throat of the child or the adult. Something happened, maybe a viral infection happened, and then the normal bacteria that was in the nose and throat then comes out, gets into the blood, and then crosses the blood-brain barrier and causes a meningitis. And then once that it takes hold in the meninges, the covering of the brain, it can then get back into the blood and then cause a cascade of effects. So there are a number of different things that can happen. And the key, as was said, is to try and start the antibiotics early enough so that the bacteria doesn't overwhelm the body, or the body's response doesn't cause damage. And that becomes a very, very important feature of what you're trying to do. The other aspect of something is when, again, one of the hallmarks of these things is very often fever. And fever is a natural sort of occurrence in terms of the body's response to an infection. But very often you may have fever without localization. So you might not have a cough. You might not have a throat infection or a throat irritation. You might not have an ear infection. You might not have anything. But you have to consider, if you have a germ that's growing in the blood, where it might come from. So very often we had in ICU individuals that had urinary catheters. If they have a urinary catheter, there's a direct connection between the bacteria that might be outside of the ureter, where it goes in. That can then cause an infection in the bladder and then cause an infection in the blood. And the treatment for that is usually to remove the catheter. You can have the same thing with the intravenous. You talked about a Swan-Ganz catheter. You can have a catheter that goes into a ventricle for someone in the brain. And very often the type of organism that's going to be grown from a blood culture in someone that has a IV catheter or a catheter that goes into to a ventricle is going to be skin organisms. Sometimes those skin organisms aren't so bad, like Staphylococcus epidermidis, which isn't a bad actor as its cousin, the Staph aureus, but even that can cause problems. And so if you have a germ that's growing in the blood and there's a catheter that's associated with it, then you look at, can we remove the catheter? Because if you don't remove the catheter, it's very hard to get rid of an infection when that infection is covering a foreign body like a catheter. And so you need to be concerned about those types of things, both where the infection might have started and where the infection might go, in terms of trying to make sure that you're taking care of the patient. Now, for Dr. Luya and Dr. Hewlett, you can comment on it. Natural selection is something that's important, because I think that when you talk about bacteria and viruses as being smart, I'm not so sure how smart they are, but they certainly react to what we might do. And so one of the problems that we face, and we saw this very often in pediatrics, is giving antibiotics when someone has a viral infection. And so you give antibiotics to someone that has a viral infection. The antibiotic kills the bacteria that are sensitive to it, but the bacteria that are resistant to it stay around. And the space that was vacated by those good germs that were killed by the antibiotic, those other organisms grow and take over and can cause problems. We commonly see this in certain situations where someone gets, and Dr. Bay touched about it, if someone has a high fever, you don't know what it is, you give a broad spectrum of combination antibiotics that kill almost everything. Mm-hmm. Well, what happens when you kill almost everything? Those things that survive are those that were naturally resistant to it, they take over. And so what then happens is you have, Clostridium difficile that causes, Dr. Mazur, you can talk about it, very, very often after you have an antibiotic. Mm-hmm. And so the use of antibiotics, not judicious use of antibiotics, broad spectrum antibiotics, and antibiotics that have a long half-life. Zithromycin is notorious for being an antibiotic that stays in your system for a long period of time, and it harbors or helps to develop natural selection of bacteria that are resistant to it. And so we end up using broad spectrum antibiotics, creating bacteria that are resistant to damn near everything, and we then end up having someone, Dr. Hewitt, could you please help us? We have this germ that's growing and it's not sensitive to everything. And right. So the natural selection that you talk about, we created those resistant organisms by the injudicious use of antibiotics. So right. That's a clear-cut way of something that we didn't do right, that harbors or creates the perfect storm with some of these bacteria that we don't have any antibiotic that can kill it.
Mhm.
Yeah. I think Dr.
Dr. Hewlett,
Hewlett,
could you comment on that?
Sure. I totally agree with you. It's always a delicate balance, but I think that part of our job as physicians is to educate our patients, and in the case of our pediatric colleagues, to educate the parents that the patient more likely than not has a viral infection and that an antibiotic is not going to work. However, it's also our job to know that if there is an actual bacterial infection that's causing that adult or child's illness, then that's when an antibiotic is indicated. And that's when we try to be as judicious as we can about the selection, to use an antibiotic that is going to be very specific in its activity. And I certainly agree with you. We are faced with things like C. difficile more often than we need to be because of the overuse of antibiotics.
Now, just one other thing that Omar, and this I
yeah.
always faced it, is, someone brings their child in or someone comes in and you tell them that they don't need an antibiotic, they think they shouldn't have come in. Unless you write a script, they think that the visit wasn't warranted. And people need to be aware that it's not as if the use of the antibiotic is harmless. It sometimes can be harmful. And the fact that you didn't get a prescription for an antibiotic doesn't necessarily mean that the visit wasn't warranted. You can be reassured or reassured. But a lot of folks can say, well, why did I come if you didn't write me a script?
That is true, and for many reasons. And when patients come to your office, they expect a script when they leave. That's for sure. Let's go ahead.
I think there's just been a shift in our culture and our mindset for patients and in kind of what their expectations are. We live in a very reactive world. We talk about the importance of prevention with vaccines, but yet, and we advocate these as physicians wholeheartedly, but yet, we've got social media, we've got misinformation kind of guiding and maybe kind of thwarting a little bit of that. And patients are also they're, as you see, even in some of the questions that we'll probably address, there's a lot of concern about vaccines and, so, well, let me try to not do this. But then as soon as something happens, it's like, oh, very reactive. Let's get you on an antibiotic. Let's clear it up despite what it is. So it's a matter of changing, and how the question here to the group is, how do we change that culture? How do we change that trajectory, which I see getting worse year after year after year, especially after that COVID pandemic?
Yeah, that's a good question. I don't know how we change it. Especially, you know why? You know why I say that? Because at this point, pharmaceutical companies are advertising to the patient and not coming to the doctors as far as what medicine is good for them. And that kind of takes a lot of our control out of our hands. When the advertisement is to the patient as opposed to educating the physician about what's to be done. So that I don't know how we're going to get around that. Maybe someone else has
Look,
some
I
ideas on that.
I can tell you, I agonize about that, Mazur. I have a daughter who's very intelligent, right? She's got 2 kids, and she'll call me about something about the child, and I'll tell her what she should do. And then she'll come back to me and said, I read these 3 articles, and this is and I shake my head. I said, yeah, you read those 3 articles. I read those 3 articles too. I said, I know how to get through and figure out what's right, what's wrong, and what's not been said. And so, you can't just go by what this paragraph says. Here's the broader picture. And then after that, she still looks at me as, well, I don't know. It's like so here you go. You got my own flesh and blood who's looking at this and saying, well, I think, and sometimes, look, her pediatrician may not be right either, but I don't know how you can combat it, because a lot of these folks get on the line, on the internet, and they start to look up stuff, and then and they're misled. They don't get the
Completely.
entire.
Don't forget Dr. Google. Please.
Completely
Don't forget
misled.
So
Dr. Google.
so right. So right. Listen. I have to do our second half. We're going into our second half. We got quite a few questions, and I know those hands are raised up there, Patrick. I want to get to you and Dr. Court, but let me do this. We're going to let me pull this down. Here we are. Okay. As far as I'd like to have everybody reintroduce themselves. Then we're going to get into our second half of our show. Patrick, please start off.
Hi everyone, hope you can hear me.
Mhm.
I have a little bit of a setup. I apologize for being a little late. I'm Patrick Anderson. I'm a gynecologic oncologist. I work with and was mentored by many of the brothers on this panel. I appreciate you all day, all night, Dr. Court, Dr. Sprott. It's always fun to be here the second Saturday of every month. I'm happy to be here.
All right, excellent. Dr. Sprott, please.
Yeah, I'm Kendall Sprout. I'm board certified pediatrician, retired. I did 15 years of critical care pediatrics. Happy to be with you.
All righty. Dr. Hewlett, please.
Yes, Dr. Dial Hewlett. I'm an infectious disease specialist, and I'm currently doing public health with the Westchester County Department of Health, and I'm on the faculty, adjunct faculty with New York Medical College.
Excellent. Dr. Court, please.
Dr. Court, internal medicine. My office is in East Orange, New Jersey.
All right. Dr. Aluya.
Yeah, Nelson Aluya, medicine pediatrics, a medical advocate. It's a pleasure to be here once again.
All righty. And Dr. Ali, of course.
Hi, Dr. Mazhar Ali. I'm a gastroenterologist with Scripps Clinic in San Diego.
Excellent. And I'm Dr. Omar Bey, pulmonary critical care, retired, now in nutrition. So I'm getting used to saying retired. Okie dokie.
Congratulations.
Yeah. Well, actually, nutrition is keeping me pretty busy, but it's all good. It's all good. No late calls at night. That's a good one. Understand that this webinar is every second Saturday, and please tell others about it. It takes a community to do something like this because we're so engaged in educating people of African descent about their health care. You can, if you want to see our past webinars, all you have to do is go to our website and just hit the YouTube sign, and actually all of our past webinars come up. So many different topics. Please go check it out. The most important thing I can say is please do not change any aspect of your medical care until you consult your physician, no matter what we say. Only your doctor, truly only your doctor can best care for you from a medical standpoint. I'd like to thank OBHealthy for allowing us to bring this webinar to you. And I think that's it. What I'd like to do is I'm going to take Patrick, go ahead, your hands up, and then we're going to get to some questions from the audience.
Yes, this question is for Dr. Hewlett, and if Dr. Sprott could chime in if he can. When you look at the number of major surgical procedures that are done annually in this country, and when we talk about the injudicious use of antibiotics and how it might contribute to resistant strain, we've often charged to prescribe prophylactic antibiotics prior to major surgical procedures. And there's a big oversight with respect to what's reportable with deep tissue infection. And if you ever not give prophylactic antibiotics and get a deep tissue infection, then that's reportable. How do you see this practice contributing to the development of resistant strain of bacteria?
Okay, that's a great question. From my perspective and as an infectious disease specialist, I like to follow the guidelines for not only the Infectious Disease Society of America, but also the guidelines for the other specialties, including specialties in the surgical areas, whether it's gynecologic or general surgery. I totally agree with you that the administration of antibiotics perioperatively is clearly indicated. Certainly in those cases where you're going to be doing invasive procedures, whether they're gynecologic or general surgical, and there are different recommendations based upon whether it's going to be a what they call a clean surgical procedure or dirty. But certainly you have to give those antibiotics more often than not. We're talking about the administration of a rather narrow spectrum agent such as cefazolin or Ancef as they call it, given the important principle as I understand it is that it should be given at least a half hour before the scalpel actually hits the patient's skin. And then it is typically given for maybe another 24 hours perioperatively. That's a general recommendation. I know that when we have situations where there may be, let's just say, there may potentially be contamination of the bowel. Under those circumstances, the recommendations go further, and they state that you should also prophylax with antibiotics that have some activity against some of the anaerobic organisms. And so you may have to take that into account for our surgeons who are doing procedures that involve prosthetic material, where they're going to be replacing a joint or putting in a vascular kind of an apparatus. Then the recommendations are different, where you're using something like vancomycin, which is going to be active against the kind of bacteria that will be most likely to cause an infection in a prosthetic material or foreign material. But to answer the other part of your question, do we think that this contributes significantly to the emergence of antimicrobial resistance? I would say I think that if this is done according to the guidance, where it's confined to that 24-hour period of time, the answer would be no. The clinical judgment of the physician has to be taken into account, though, because if the physician during his or her procedure notes that there's some sort of a complication, let's just say they think maybe there may have been a nicking of the bowel, for example. Maybe there was something that caused a prolongation. Maybe there was excessive bleeding. And in the opinion of the doctor, they feel that infection in that particular patient is more likely to have occurred. That certainly justifies continuing antibiotics for a longer period of time until you see how that patient is doing post-operatively. But that's kind of how I see it. I think that you have to use antibiotics prophylactically, and I think that it's well accepted, and I would agree with you that the failure to administer antibiotics prophylactically and then the subsequent development of an infection in a given patient is something that would be viewed as, I guess you would say, something that would be against the standards of care. I hope that answers your question.
It certainly does.
Yeah,
I mean, and there are a lot of things.
Yeah, Patrick, you threw me in on that as well. I think for me, the common thread is, as Dr. Hewlett said, is you're trying to protect the patient against something that you are expecting. And what you're expecting is a procedure that might cause bacteria to get into the blood. And so in pediatrics, we have individuals that have either shots, VP shots for ventricular peritoneal shunts because they have hydrocephalus, or they might have cardiac valves or damage to some of the leaflets. And if you get bugs in the blood, they can hit those damaged leaflets, or they can hit the shot that's very, very precious to them. And so if you're going to have a procedure where you know there's likely to be bugs in the blood from that procedure, then you need to have the antibiotics on board when the bacteremia is expected, and then for a short while thereafter. And it depends upon the invasive procedure. If, as Dr. Hewlett said, you have someone that has a valve, and then they're going to have a colonoscopy, then you're going to cover for the gram-negative bacterial organisms that might get into the blood. If you're going to have something done with the skin, you're going to have to cover for the organisms, the staph and strep that are going to be on the skin. But I think when you use a short-acting antibiotic for a short period of time, you lessen the risk. I can't say there's no risk, but you wouldn't want to use, as I mentioned before, something like zithromycin that's going to stay in the blood for 5 days. Because whenever you have a long acting antibiotic, you increase the risk of developing resistant organisms. And so I would say that for most cases of prophylactic antibiotics, they're very short. You want to put that maybe an hour or half an hour before the procedure or the expected bacteremia, and then for a couple of doses afterwards, and then you're done.
Mhm.
Excellent, excellent, excellent. We have quite a few questions come up on our board here, so let's tackle a few of them real quick. First one is there is apprehension that vaccines, i.e., COVID-19, will cause harm. I gather the way it's where it's written to the genetic makeup, meaning that the patient's genetic makeup. What would you or it should state, how would you address this? So I gather they're thinking about the vaccines may cause harm to the person's genetic makeup, or the way it's written. I'm not sure if they're talking about the person's genetic makeup or the organism genetic makeup. It's a little confusing, but I know that some of my patients were a little hesitant to take the vaccine just because it was a new vaccine. The vaccine was different from other vaccines, and whether it was going to harm the patient in the long run because it was so new. And I think that's what the question is asking.
Okay, I can start to tackle that. That was something that a question that we got quite frequently, because the initial COVID vaccines were messenger RNA vaccines. There's no data to actually show that there's damage or change to a person's genetic makeup because of the use of these vaccines. There's actually I guess one of the things that comes up is for people to say, well, can you actually prove that to me? The only thing that we can say is that there is a national registry of vaccines and of what we call adverse reactions to vaccines. And the adverse reactions to the COVID vaccines overall, over a period of, say, the 3 or 4 years that they have been in use, you actually express them in terms of the number of adverse reactions per million doses. That's how infrequent the adverse reactions have actually been. But the RNA that is present is not something that is capable of actually entering cells and making genetic changes. The other thing which I think you should know, or the person who asked the question, is that if there is still a great amount of concern about this, there are actually now COVID vaccines that are what we call protein-based or protein-derived COVID vaccines, which do not contain the genetic material. And so if what I've said doesn't allay a person's fears, they can still get a vaccine that is protein-based, and it would actually be protective as well if a person really isn't convinced.
So, Dr. Hewlett, I take a different approach.
Go ahead.
The issue is, why are you taking the vaccine in the first place? You're taking the vaccine to prevent yourself from having the ill effects of a virus.
Yeah.
And so if you get exposed to that virus, your body reacts to that entire virus. And that virus will enter into your cell, take over the architecture, and reproduce itself. And in and of itself can alter your genetic works within that cell and possibly cause more harm to your genetics than pieces of the virus that are part of a vaccine. And so again, what most of the vaccines are looking at is, well, how does the virus get in, cause harm? And so if we can take certain components, proteins that are coating or on the spikes or the various types of proteins, and develop a vaccine so that your body recognizes those spikes or those proteins, and when it sees the virus, attacks the virus so that the virus can't attach or get into the cell. And so you're much more likely not to have any genetic alterations to yourself from a vaccine than you can with the actual infection. And so, and what are the consequences of the actual infection? Death. You take your risk. And so the many vaccines are different. When we talk about measles, mumps, rubella, we talked about live attenuated viruses so that they weaken the virus and then they expose you and then your body reacts to it. But your body reacts to all of that. And so if it sees a naturally occurring virus, it attacks and removes it. Other types of vaccines are only parts. We with whooping cough, we had killed pertussis. And there are a lot of reactions to the killed pertussis. Your body reacted and it started to attack the whole pertussis, but there are a lot of fever and other things that were associated with it. And then they came out with acellular pertussis. And so these vaccines are designed not so much to cause genetic aberrations, but to try and prevent that actual bacteria or virus from causing harm to you. And so the issue of almost anything you talk about is what's the risk benefit analysis. So the issue is if you're going to have an infection from a whole virus, lots more likely to have a problem with that than actually from the vaccine, in my opinion.
Totally agree.
Yeah. Let's get another question before we go on to and take some of the hands. But don't forget, I know there are a lot of hands up, but we have a lot of questions too. So let's move. We're going to move along here. Greetings. My name is I think this is Daya. I'm going to pronounce. Excuse me for mispronouncing your name. I would like to know what are the potential risks and complications associated with a low white count, 2.87, in the context of viral infections, and what steps can be taken to minimize these risks. So, 2.8, yeah, that's a low white count, and associated with that, I know that there are many things that we can say about a 2.8, but Dr. Hewlett, do you find this with viral infections? If there anything a person can do to help themselves?
Certainly, this is one of those situations where this should be discussed with the patient's physician, with the person's physician. We know that there are some people who have low white blood cell counts on a hereditary basis, and it actually causes not much harm at all. But we do know that many viral infections can cause a low white blood cell count. And so it is important, if this is something that has occurred in conjunction with an illness, that they be evaluated to try to determine if there is an infection that is causing this. There are many other things that, of course, can cause low white blood cell counts outside of infections. And so that's why it would be important for the person to be evaluated by their physician. The physician may actually, if there's no obvious explanation with regard to this in terms of an infection, might evaluate them with in conjunction with a hematologist or a blood specialist to see if there might be other reasons for this low white blood cell count, because there are some even nutritional types of deficiencies that can be associated with low white blood cell counts, things that can be rather easily corrected. One other question which I think came in with this is, are there consequences to a low white blood cell count? And we do get concerned when people have not only low white blood cell counts, but there's a particular kind of white blood cell that we call the neutrophil or the poly. And if they have a low neutrophil count, then they are at risk for the development of bacterial infections, which can be very serious in that particular setting. And so I think this gets back to the whole issue of having a physician look at this and analyze all of this, not only the overall white blood cell count, but part of the report which the doctor gets is what they call a differential count, where they look at the different types of white blood cells on that panel to determine which ones may be low and which ones might be high.
Excellent. Let's do one more question, and then we're going to get to some hands. But And when we do get to the hands, we're going to keep our answers short because we got quite a few questions, and I really want to answer the audience's questions. For an international traveler, what over-the-counter medications do Dr. Hewlett suggest carrying to help support the immune system?
That's a tough one. I think that we routinely recommend that people take anti-diarrheal types of medications. And there are a number of over-the-counter preparations which people can take. There are situations in which antibiotics may be helpful. And I know that sometimes people may be hesitant about this, but there are, I think, again, in conjunction with the person's physician, one may consider these. I think it's important, though, rather than just looking at things that are over the counter, it is extremely important for the person to consult with a physician or to consult with the Department of Health, because they actually have listings of the various types of things which need to be done before traveling to certain parts of the world. One of the most important would be anti-malarials, which are not over the counter, but which are extremely important if one is going to go into an area where there's malaria. And I think that yellow fever is something that has become much more important, and making sure that you are protected for yellow fever. And I think obviously you have routine types of medications which can be taken in addition to the diarrhea, things that, are just sort of anti, for digestion and that sort of thing. But
Excellent, excellent. Dr. Aluya, you had your hand up and patient, and thank you very much.
Yeah, I mean, yes, good, thank you. It was more like a question and then a contribution. With regards to the question that was just answered by, Dr. Hewitt with regard with the white blood cell count. I mean, he totally just nailed it. The question is, there are issues where people run low, and that's what they are. We need to understand that the numbers we have are basically average. The white cell count of 3.5 to 5.8, or in different places up to 6 in different labs, are just averages of what the people who have been sampled over the years, basically like 75% of the population in the community, that's what the average is. But some fall above and some fall below. Now, in my office, I've been asked multiple times all through, why is my white blood cell count low? And I've noticed empirically that certain tribes of Nigeria, I'm not going to mention names or tribe, I figured that certain tribes of Nigerian origin and predominantly people of West African origin tend to run low. But they're fine. There's nothing wrong with them. There's no complications, nothing. Now, some of the things I've always thought about that, is it the food? Is it genetics? Is it whatever? So probably, yes, these things will run. And the question of that person is, what was your initial white count before it came down to 2.8? And that's what was your baseline? And that's something anybody needs to know. If there's anything anybody's going to take out of here, know your baseline every time, anytime. And that's why it's important you go see your doctor and have at least one annual physical every year where you sit with the doctor, and mandatory, you have 30 minutes to sit with your doctor. We've talked about that here, what it entails for you to sit and have a one-on-one discussion with your doctor on an annual well visit day. So that is so important. Now, my question to Dr. Hewitt, what are the risk factors that would improve or augment your immune status? And what are the things that will, what do you call it, make them deranged or reduce them? We've often talked about the biomatter, right? Which is the total amount of the organism in your body. Does that differ from race to race? And how does that improve or determine your immune status?
you're asking some very tough questions, Dr. And I don't know if I've got answers for that in terms of the biological things in our gut. I do know that from the standpoint of our immune function, and we learned this from COVID, that some conditions cause chronic inflammation.
Right.
And if we're able to manage those conditions, that our immune system functions better, specifically obesity. We know that obesity causes chronic inflammation. And if we are able to start to work on ways to control our weight, that this actually improves us immunologically. We know that diabetes also causes chronic inflammation, causes a chronic vasculitis, if you will. And that's another condition in which if we can control that, that really improves the person immunologically. There may be a lot of other things to do as well, but those are some things, some very tangible things that I would put on the table.
Excellent, excellent. Patrick, as you're up, Dr. Anderson.
Yeah, I have so many questions for Dr. Hewlett and Dr. Sprott. But the most important one for me now is, and I see it in patients in whom I recommend, for example, chemotherapy. And the question they often ask, well, the therapy kills the good cells, right? And why should I have chemotherapy? I kind of parallel that with sometimes social opinion as to vaccination. And one thing that I struggle with, for example, with the HPV vaccine, with parents saying, well, why should I give it to my youngster? It makes them more promiscuous, makes them want to engage more. How do you change the conversation to get folks to understand that vaccination is prevention and it's less harmful than beneficial?
That's another tough area, the HPV vaccine. I think that there's a lot of education that certainly is needed. And I think that one of the challenges that we face, and I think we in the African American community face it maybe more so than others because we don't realize how conservative many people actually are, is that this is a known factor for the development of anogenital carcinoma and cervical carcinoma, and that this is something that can be prevented, at least certain forms of it, by the vaccine. I don't know if we have to make more extensive use of statistics or the actual incidence of these types of cancers. If we go back to the original Henrietta Lacks types of discussions, the kind of cancer that she actually had, cervical cancer, you can actually prevent many instances of it with the HPV vaccine. But we go through this at our health department a lot.
But,
So for me,
especially HPV
Patrick,
vaccine, that's one of the ones that affect cancers at both ends of the body, buccal oral cancers as well.
Yes, oral, laryngeal, yes, head, neck.
so for me, Patrick, I'm no longer practicing, but I think that at the time that the children start to undergo puberty, and for females, especially African American females, the average age that they're starting to have their menses is around 11, which means that they start to their pubertal changes a couple of years before that. That's just average, so maybe around 9, but some are even before that. But once you start to see that someone's undergoing their pubertal changes, you have the discussion about what those changes happen to be and all the issues related to possibilities of them having sexually transmitted diseases, or in the case of HPV, an infection that might later on, 10, 15 years later, end up with cervical cancer. And so you're talking about the possible administration of a vaccine several years before they actually are going to become sexually active, hopefully. Mm-hmm. And so it's not an issue of this vaccine making them sexually promiscuous when they're first starting to have the pubertal changes. And the same sort of conversation occurs with the men, because in order for you to be able to prevent these cancers from occurring with these various types of HPV, you need to get it done before they get exposed to it. And they're more likely to get exposed to it through sexual contact. And so if you can get the vaccine done before, then before they're going to become sexually active, then you don't have this issue of promiscuity. I think a lot of the promiscuity might occur with things like IUDs more likely than that. But there's, the issue of promiscuity and when they have sex is more related to the relationships what they have with their parents and the issues of trying to get them to understand peer pressure that's associated with this, especially as social media has become more and more prevalent. And that's what is most important about promiscuity and not so much the vaccine.
And if I can piggyback onto that as well, the other place where we get a lot of pushback is with PrEP, the preventive medication for HIV. And as a group, African Americans and people of African descent here in the United States have the lowest uptake of PrEP. And PrEP has been extremely effective in preventing HIV from occurring. And we still have the highest rates of HIV of any ethnic group within the United States. And these are discussions that we need to have. And I think it's along the same lines.
Patrick, you raised another issue, and I think that it is important. And with chemotherapy, it does kill lots of normal cells, but certainly the cells in the body that naturally grow or replicate quickly are affected. And one of the things that happens is that the white cells, particularly, are responsive to a lot of the chemotherapeutic agents. And so, if we had, for example, kids that we were treating with leukemia, which sort of the chemotherapy knocks out the bone marrow, including the white cells, we should pay particular attention to the type of white cells that Dr. Hewlett talked about, the neutrophils. And so when you do that complete blood count and you look at that differential, you look for the neutrophils, the counts we call neutropenia or low neutrophil count under 1,500. Between 1,500 and 1,000 is considered mild, 1,000 and 500 considered moderate, and under 500 severe. And the issue becomes that, remember, I spoke about the fact that you have bacteria that covers your body and covers your mucous membranes, your nose and your throat, and the lower part of your GI tract. What happens as the neutrophil count gets lower and lower, below 500, even those cells that don't cause harm normally can start to cause harm. So you need to pay particular attention to those individuals who are getting chemotherapy to look at those neutrophil counts. Because again, one of the signs or hallmarks of infection is fever. And fever has a lot to do with those neutrophils helping to fight the infection. And so you might not have the kind of fever in a patient that's gotten a chemotherapeutic agent because they don't have enough neutrophils to mount much of a fever. So you might want to give those individuals antibiotics a lot quicker with even mild temperature elevations than you would with someone that had a normal neutrophil count. And so it becomes important that when you look at the complete blood count and you look at that differential, you see, well, how many neutrophils are there and are they falling and are they reaching a point where I need to be very, very careful about maybe trying to put someone on possibly prophylactic antibiotics. Even though you might not think that they have a big infection, they can become very, very sick very, very quickly when their neutrophil counts are very, very low.
Excellent.
Yeah, but this is clearly one of the conversations that drives this narrative, right? Because when we talk about prophylaxis, that's exactly what a vaccine is, right? So the question now becomes those same patients with the neutropenia or the low white count when being treated for a chronic illness like a cancer, shouldn't those patients also be considered to have prophylactic vaccination?
Well, I totally agree with you, because if we fail to intervene with antibiotics in a patient who has fever and neutropenia, we call it the febrile neutropenic situation. What we know is, as Dr. Sprout said, when that white count, if that neutrophil count is at 500 or below, and if that patient has a temperature elevation, let's just say of 101, they've got a 20% chance of having a bloodstream infection. And more often than not, it comes from the GI tract. If it's down to 100, then I think it goes up to something like 40 to 50%. So you don't really have any time to waste with patients like that. So those patients, unfortunately, we have to treat them empirically. And if we don't isolate any bacteria after, I think, 72 hours, our guidelines say you stop. But if you take the blood cultures, and if the cultures are positive, then you basically have treated the patient. The analogy that I like to use for our patients is that think of the antibiotics as being a bridge over the valley of neutropenia that has been caused by the chemotherapy that is necessary to treat the cancer. And so the two work together, and you have to treat that cancer, and that has to be treated with the chemotherapy. And we have the antibiotics to help you bridge over that valley until the patient is on the other side, and they hopefully will have a cure of the cancer, and also they will have been treated for the antibiotic.
Mm-hmm.
So Patrick, the other important aspect, and you know, the spleen is an important organ in terms of infection, in terms of being able to trap bacteria and have white cells catch them. And so people that have their spleens removed or destroyed, like it because of sickle cell, they damage it. They can become susceptible to certain type of bacterial infections. And so it's important, critically important, that they get the vaccines before they have damage to the immune system, before they have a splenectomy, or if they're getting chemotherapy, if they need a vaccine, they need to get it before they have the chemotherapy, not after. Because, you know, we talk about smart bacteria. We got some smart white cells too. And if these white cells are exposed to the vaccines, they can develop memory, if you will, so that they are waiting in effect for bad actors to come. And when they see them, they can mount a response and replicate themselves. So it becomes important that if indeed you know that someone's in need of a vaccine and they're going to have chemotherapy or they're going to have a splenectomy or something like that, that they get the vaccine before that occurs so that those white cells can be vigilant, ready to attack the things that they may be exposed to that might cause them harm.
Excellent, excellent. Dr. Ali, you have been patient. Thank you very much.
Well, I've got a few points I wanted to bring up.
All right, let's rock and roll.
One, I think this was a piggyback from a comment Dr. Sprott made just about kind of vaccination in general and making, deciding to do a vaccine and that risk benefit ratio, for the audience out there, and a very common analogy that I use that maybe helps to put things into perspective is, everything in life has got some level of a risk, right? We get in our car and drive from point A to point B to go to work or to go visit family or whatever it is, to go to the grocery store. Why? Because we need to live our life. And there is a risk of a car accident. There is a risk of getting injured on the way or anything else or traveling, right? But I use that analogy to think about medicine and making your decision about doing anything in medicine as well, right? We take a medicine because we want to feel better to keep living our lives. So when you decide about something like a vaccine or a medication that you may see a long laundry list of side effects and it may make you nervous because you may have a chronic condition, you may just need it. Think about the fact of the risk benefit ratio. And to live your life, to live a fruitful, healthy life, these things are designed, and we live in this age of technology where we have this fruit of this labor that we can enjoy, and we can really optimize our life for longevity, good quality. So think about that from that risk benefit ratio. Yeah, there's risks with everything, but there's an overwhelming benefit than a risk. So that's kind of one point that I wanted to make kind of to the audience. Second, I did have a question to Dr. Hewlett about some vaccines. I know that there was relatively recently a recommendation, or was there an age change for the RSV vaccine?
There was, and I think that it went down to, I'm trying to remember now, I should know this, down to 65, I think, and older. I think that they went to a universal kind of a recommendation in terms of just a general recommendation. And I'm trying to remember if it was 65 or 60. I would have to look that up. But meaning the ACIP did actually make that recommendation.
Yeah. And RSV is respiratory syncytial virus. I take care of a lot of patients as a gastroenterologist with underlying autoimmune GI problems like Crohn's disease, ulcerative colitis. I see a lot of people who take these chronic medications to control the disease, but one of the side effects, if you will, one of the adverse events that's always kind of been reported as well, because it's working with your immune system has dropped a little bit, even though I tell people all the time, your immune system works fine, and even optimally when your disease is best controlled, we always try to take a very proactive vaccination strategy.
Yes. Yes.
So for these patients, a lot of times these patients who have Crohn's and colitis, particularly, they're younger patients, right?
Yeah.
Is it reasonable to put people, even though that recommendation's at 65? I know when it comes to like pneumonia,
yeah, there are risk categorizations for it as well. So the universal is by age, but then there are specific risk groups, and I think your inflammatory bowel patients would fall into that as well. And then we put a plug in, and I think that Dr. Bay will agree, for tuberculosis screening in those patients, because we actually just saw a woman with resistant tuberculosis who was on one of the agents for her rheumatoid arthritis.
Yeah.
Okay. And then
Dr.
the other
Mason,
question, sorry, one more question before HPV. I know we talked about HPV vaccine a little bit, and I meet a lot of people who've never gotten that vaccine and they're on some medications. At what point, I know that, the best window of opportunity is that younger age prior to becoming sexually active, and that cutoff in our guidelines is usually up to about age 26. But how late can you go? Like, how much can I push that? And, I know that as you get older, I may not catch that window, but if I've got like somebody in their 40s or in their 50s, is it reasonable to say, hey, you should get this vaccine?
Yeah. At the upper age, and the data clearly shows that there's benefit given up to the age of 45. But I think, if there was a biomarker that can indicate response to vaccine, and probably a T cell response, if there's a cheap, reproducible method of measuring T cell response to any vaccine for that matter, but particularly HPV vaccine, that could actually extend the age range up to who would benefit, the upper limit benefit from having that vaccine. So right now the recommendation is between age 9 to 45.
Mm-hmm. Mm-hmm.
Thank you.
Yeah.
Thank you.
But I think the reality is that you never know which of the strains that might predispose to develop a cancer you've been exposed to or not been exposed to, and whether or not you're going to be exposed to them in the future or not. So I think that's sort of the reality. If there's strains that you haven't been exposed to, that the vaccine might prevent you, if you got exposed to it, that might be of some benefit. I think the part of the issue is how many sexual partners you're going to have after the age of 40 or after the age of 35 or anything like that. But I wanted to touch on the RSV issue. RSV, for the most part, respiratory syncytial virus, is something that I treated a lot. But most of the folks that had problems with it were under the age of 2. Because this is a virus that infects the lining of the airways, the respiratory syncytial, and they get in and they destroy them. And so there's a lot of debris that gets left in the airways, and it becomes difficult for the patients to get rid of the debris because those cells that line the respiratory tract get rid of mucus. And so you can't get rid of it if you don't have those sweepers that line the airway. And part of the issue with it is that because they're destroyed, it takes several months for them to regrow. And so there's a chronic cough that occurs with it. And the reason that these kids are so prone to have morbidity and mortality is because their airways are very, very tiny. The airways are still developing. The other aspect to it, which is unique to RSV, is that somehow or another, your body, your immune system doesn't develop memory against RSV. So that unlike other kinds of viral infections, you get exposed to RSV, you go through the cycle where your body gets rid of it, you get exposed to RSV, there's no memory of those cells to sort of take care of it, and so you can get it again. I'm not so sure, this is me not knowing, and you might know more than me, Omar, how deadly or serious RSV infections are going to be in adults who have pretty big airways, unless you have chronic respiratory disease. And so, because the airways in adults are much, much larger, even if they get RSV, I'm not so sure how sick they're going to be. Unlike these tiny kids that have very small airways where they can get air trap and need respiratory support and everything else. And there is monoclonal antibodies against it. But, I'm a little concerned about the pharmaceuticals making a bunch of money on stuff that may not be entirely necessary.
Yeah.
So I'm a little concerned about the recommendation of RSV vaccines in adults because I'm not so sure how big a problem it is.
I
I
understand what you're saying. I guess going by the data, one of the things that has been shown, and this is without any bias for a company at all, if you look at pneumonias, or if you look at infections that are occurring in older people, RSV and influenza occur at sometimes almost the same rate. And in people who are older, the mortality rate seems to be pretty similar. So,
excuse me, Dr. Hewlett, excuse me. Somebody, they have a background, somebody's listening to something in the background. Could you mute yourself if you're listening? Go ahead, Dr. Hewlett, I'm sorry.
Yeah. So I think there is enough data out there to support giving it not to every single person, but certainly individuals who are certainly, I know it started out at over age 75, but I think over age 65, most certainly the people who are with chronic respiratory disease, and I think most certainly people that are in long-term care facilities. That's where I think it's been shown to have the greatest amount of benefit. The other place where I do think that it's worth discussing is it's one of the few vaccines that is recommended for use during pregnancy, not to protect the mother, but to protect the unborn child if they're going to be born at a certain period of time in the respiratory season. So I'm trying to remember the actual months, but if the child is going to be born and they're going to be at risk during that period of time in the wintertime, then that's when they should receive it.
Right.
And
So
from a critical care point of view, Dr. Sprock, I think about it as adults getting a lung infection, and you think about other comorbid problems. Do they have diabetes? Are they obese? Or do they have kidney disease? All of those things are compound when you're an adult. You're over 50 and you get RSV and you have, my typical patient that comes in the ICU, they have hypertension, diabetes, they have hyperlipidemia, they have some heart failure, they have a little COPD, they have a little, and you understand when you put all that package together, it's significant. It can be deadly.
So,
I
so
share.
my only comment is that I'd say 95% of kids that have RSV, it's an upper respiratory tract infection.
Yeah.
It's
Yeah.
not a lower
But
respiratory
kids,
tract.
you
No, no, no,
understand,
no, no,
kids,
no. Let me
kids
just
have
let
all
me
those
just
new organs, you know?
no, listen to what I'm saying. So
got
and the same thing goes for rhinovirus.
Right.
Rhinovirus is almost exclusively an upper respiratory tract infection. It's the lower respiratory tract disease that's going to cause a problem. And if I got it, if you got chronic respiratory problems, you probably might benefit from it. But outside of that, the kids that were recommended to get the monoclonal antibodies were the premature babies that would be prone to develop not only bad disease with RSV, but also go on to develop asthma or reversible airway disease if they got it. So that I understand. Older folks, I'm still not.
Well, see, that's where we differ, because I see these people in the ICU, and I see how.
Yeah, but you probably don't see the 98% that never even saw a doctor when they had it.
I share Dr. I share probably because I'm a pediatrician as well, and I share his concern as well, because look, RSV has always been with us, always, and we see more in kids than we see adults, and all of a sudden within the last 2 to 3 years, especially after COVID, then there's an explosion of RSV and adults and all. And the vaccine they talk about, what's it called, the Neserveb, it's not an actual vaccine. It's a monoclonal antibody. But now they use the word vaccine, and it's put out there by the pharmaceutical company and all that. The question is this: what's the true intent? Is it patient care, or is it revenue income or revenue cycle there? And that's where we come from.
One thing
to address issues.
Yeah, one thing I think that we have to keep in mind is that the pharmaceutical companies cannot, and I'm not defending them, they cannot market any product without having it go through two steps. It has to be approved by the Food and Drug Administration, and these products were approved before the current administration. And then it has to go through a review by the panel, the Advisory Committee on Immunization Practices. And that's a panel of people from the academic community who actually review all of that data, and they actually decide, assuming based on what the FDA said it actually works, is the product actually then going to be indicated for certain populations. And right now, you actually have, I think there are probably 3 or 4 different manufacturers who have products in this area. So I think just to keep in mind, it's not just the companies who come out with it and then just start to put it on television. They have to actually go through that whole review process with, the 15 people on the VRPEC for FDA. And before everything else happened, those were all very honorable people working under Dr. Marks. They were honorable people. And then you had, they weren't in the companies at all. And then you had the ACIP, and none of those people are associated with the pharmaceutical industry. They can't own stock or anything in the pharmaceutical industry. And they then make their decision based on the data. So I guess, certainly there obviously was some sort of a financial incentive for the companies to develop this in the first place. But I do think that they were able to show when they presented all of this data that there was an unmet need. And I think that they actually did show that a disproportionate number of the people that had the rather serious complications from RSV were people who were from underserved types of communities like the people that we serve. So
Dr. Hewlett, these monoclonal antibodies.
Hold on.
HIV.
All right, hold on. Dr. Aluya, then Dr. Sabrak, and then we go into Patrick.
Right.
Dr. Aluya, you're on.
Doc, is HIV and tuberculosis on the decrease in the United States?
HIV and what?
And tuberculosis, TB, are they on the decrease?
They're on the increase. We've had in the United States and in our county, we had a 25% increase in active tuberculosis cases, and nationally, it's on the increase as well. HIV, we're facing an epidemic of HIV in our African American community, and I think a lot of it is because we do not use PrEP. Although I know one could argue, well, the pharmaceutical companies are making a lot of money from PrEP, but we are the ones who are not really using it, and we're the ones that are getting infected. So hope that answers that question.
Dr. Sprock, please.
Yeah, and Nelson, you can chime in if you want. Monoclonal antibodies, again, are not vaccines, and they are extremely cheap, aren't they? They're the most expensive drugs or bio. They don't call them drugs, biologicals that exist. And so it's been my opinion that the most expensive medications or biologicals are more likely to be administered to people that have money than the people that don't have money.
Oh, yeah.
And so when you get to the issue of risk benefit, and again, most of the biomedical research that's being done at one point was, I'd say, NIH, but outside of NIH is done on behalf of pharmaceutical companies. And yes, there are lots of honorable men that are involved in the research. I dare say that there's some folks that are involved in clinical research on behalf of the pharmaceutical companies that are less than honorable.
Sure, I couldn't argue. I couldn't argue that.
I'm sure.
As far as RSV is concerned, I think the vaccines are different than the monoclonal antibodies. So there are vaccines that are actually not in that category of monoclonal antibodies. And those are the products that I think have been most recently approved because they went through the ACIP process over the last couple of years. So I think we're talking about different things when we talk about the monoclonal.
And one of my questions related to that, given the inability of the kids, at least, to develop long lasting antibodies against it, how long the protection is going to be after several years?
Yeah.
Because we've seen a number of vaccines that over time, the waning of the protection as the antibody levels start to decrease over time. And particularly RSV is one that I'm concerned that might be the same thing.
Yeah, no, I understand. So,
Yeah.
That means that they have to keep getting the vaccine.
you mean the kids?
No, the adults.
Oh, the adults. Well, I don't know. I think they actually did look at how long it would last. And I think they had data for out to maybe 2 years or something like that.
It's not that long.
No, it's not. It's not.
Patrick, yes, sir.
Yeah, this is more of a comment and then a question. You know, this kind of discussion is great for the audience, right? Because when our thought processes are aligned, they get very direct and very clear information, right? But they must also understand that we don't always agree, right? But and the message from that is the conversation is important because ultimately we'll come together and deliver a point. It's one that's well thought out. The other question I have, though, you know, if you look at the time frame between the time of COVID and the time to develop a vaccine, may I ask Dr. Hewlett, what's preventing us from developing a vaccine against HIV?
That's been a question that's been out there since HIV started. And I don't know the answer about all the science. What I heard was that the vaccine seems to be so elusive. I'm not the vaccine, but the virus seems to be so elusive in terms of the changes that it makes that it was very difficult to actually come up with a vaccine that would be effective. Now, what is available now, and one can argue about this, is the product that just came out. I think it's called lenacapavir. That is something that is given twice a year, and they're looking at a study now where it only has to be given once a year, and is probably close to 95 to 98% effective in preventing HIV. Now, and this is based on studies that were done on the African continent. I think they're running studies here in the United States. But if you have something like that, that might be almost as good as having a vaccination. But of course, you're talking about a product that has to be given probably at minimum once a year. That's what they're looking at right now. But the studies that were done on the African continent showed that it was effective. And these were in women if it was given like twice a year. So.
Yeah, I'm not thinking on HIV because of a social stigma, because there are also other viruses that one could ask the same question, such as HSV, right? We haven't had we have therapeutics, but we haven't had a vaccine against those viruses either.
Right. No, I understand.
Dr. Hewlett, there's been a number of attempts to look at the development of killer T cells to weaponize them against certain viral infections that have a predisposition to cause cancer. And so one of the questions is whether or not there might be the ability to take either individuals or people that have the same kind of haplotypes or the, makeup to weaponize white cells, killer T cells against things like HIV. Has anyone started to look at that? You look at some of the cancers that have been associated with it, and they developed killer T cells to attack that. Those killer T cells tend to exclusively attack those cells. Dr. Mazur, they did something with colon cancer with weaponizing killer T cells.
I've heard of it. I haven't really dived much into the details or with the data.
But
Yeah.
to me, that's one of the areas where, again, your own white cells, the pharmaceutical companies can't patent and make money off of. But that's something that if that were to work, it would be something where your own immune system is weaponized to attack this kind of viral or those cells that are infected with that virus.
Yeah, yeah. I'm not aware of that kind of research. I mean, I have heard about it in terms of other forms of cancer, but I don't know as far as HIV is concerned.
Because they've developed killer white cells to attack the coronavirus.
Okay.
Well,
Yeah.
those
It's-
things are
it's-
huge and they're up and coming. I think it's a segue to the question then to Dr. Hewitt. Like I always say, technology answers everything, and we evolve with technology. Now in the age of AI, talking about CRISPR, mRNA technology, and including AI. What's the future of infectious disease, and how do we take care of ourselves and prevent disease?
Well, that's a tough question again. What I do know about AI and infectious diseases is it's not just infectious diseases, but it's like all of medicine. I know that it's been applied to the use of antibiotic use and antibiotic stewardship. That's one of the places where they do want to apply it. So whether we like it or not, we are essentially somewhat controlled by our institutions, and antibiotic stewardship is one of those areas they're definitely looking at. One of the other areas which I think is fascinating is really more in the oncology sphere, where they're looking at hundreds of thousands of MRI scans. They're looking at hundreds of thousands of mammographic images, and they're looking at this from the standpoint of sequentially following the patients who were eventually diagnosed with a cancer and then the patients who were not, and what actually is on that scan from like 10 years ago that tips you off that there actually might be a cancer, so that you would be able to pick that up from 10 years earlier. That's my little, understanding of the potential applications for AI. But when we had our infectious disease meeting last November, they gave us a book about AI, and they said, if you're not sitting at the table, you're going to be on the menu. So as doctors, we had better learn about it, because it's definitely going to affect all of our practices.
Right. At this particular point, I hate to say we have to call this to an end, but we're gonna have to call this to an end. We're over time.
Okay.
Dr. Hewlett, just to let you know, there were several things that I wanted to cover that we didn't cover. There's one of our ID doctors at the hospital, and he always states that the one organism that's going to get us as a human species is fungal. And he's like, that fungus that's the one
Among us.
I'm scared of,
Yeah.
I,
Candida
I,
auris.
I trust we could have time to talk a little bit about fungus, and then, of course, tuberculosis. As you stated, it's on the rise, and especially in our communities, and it's one of those things that we should truly have under control, but we don't. And
I'll be happy to come back at some point if you want me.
we love you. We love to have you. Listen, we'd love to have you come back. And the second thing with Dr. Ali, I wanted to discuss C. diff because it's so common, and it's something that so many of the older patients have because of antibiotics and stuff, and how you deal with it. These are some of the things I wanted to cover, but we have to cover them at another time. But Dr. Hewlett, what I'd like to ask you to do is just sum up, because we covered a lot of area today, and just what's important from your perspective that the audience should know, and sum up for us on infectious disease.
Well, thank you. The thing I think that the audience should know is that when we talk about infectious diseases, and when we're talking specifically about communicable diseases, some of the communicable diseases that we know about are preventable. They're preventable with vaccines. And so, of course, everyone knew about COVID. That actually is, we can prevent hospitalization and death through the vaccines. Measles. As Dr. Sprout indicated earlier, you had children dying from measles. There are at least 3 deaths from measles None of those children should have died because the measles we thought we had eradicated back in the year 2000. And so no one should get the measles anymore. We have an outbreak of whooping cough going on around the United States and in certain parts of the country. And we know that you have small children, infants, who are too young to be vaccinated, and they are actually getting the whooping cough. And this shouldn't be happening. This is a vaccine preventable illness, vaccine preventable disease. So I think if we can at least have thoughtful conversations with ourselves, have thoughtful conversations with your physicians if you are in doubt about the effectiveness and the safety of vaccines, because I think we can do a lot to protect our children and to protect our community. And finally, I think for those who are adults, there are things that we can do to prevent infections like HIV. And I think that there are things that are available that people can take. The PrEP is something that I encourage people to think about. And it's very effective in preventing HIV infections from occurring. And we as African Americans are at a higher risk than anyone else of getting these infections. So I think taking advantage of the preventive measures, as we say, as I like to say, an ounce of prevention is worth a pound of cure. And it's much better if we can prevent these things than necessarily having to be in the hospital for us to have to cure them.
Well, thank you very much. Thank you for taking the time to come and be on our webinar. It's been a pleasure, and that invitation to come back, you know I'm coming after you. You know that.
I know, and I know you're out in South Orange, and my son and daughter-in-law and my granddaughters are in Maplewood, so I'll
Right.
have to make sure that I look you up.
Oh, please do. We gotta get together, go out to dinner.
Okay, that'll be fine.
Great restaurants around here.
Okay, I'll
Yes,
take you
sir.
up on that. Okay.
Yes, sir. Well, the thing of it is that in closing, I would like to thank OBHealthy for allowing us to bring this webinar to you. Without them, I'm telling you, this platform just couldn't happen. Remember, our webinar is every second Saturday at 1 o'clock, and please, go on and check out our past webinars. The topics are awesome, and you just need to just review them and understand. If you have a problem, just go listen to it. It can get some clarification. If Please subscribe to the to that YouTube so that we can keep bringing that to you and in that frame or that form. Caring and sharing, please let others know. It's important that we realize that it takes a village for us to heal ourselves and bring knowledge to you. The most important thing I can say, and I always say this, please do not change any aspect of your medical care, no matter what we say, unless you consult your physician. Only your doctor can truly take care of you from a medical perspective. All righty, and just understand we will be here next month. I look forward to all of the audience coming back, and tell friends and family so they can join us. Dr. Hewlett, thank you very much for taking your time and bestowing your knowledge to us, because I learned a lot today as well. And everyone, we're going to see you next month. You take care out there. Peace.
Thank you.